characterize some of the different types of acute inflammation, and then we're going to get to a little of the mechanics or the mechanisms of some of the signalers, and then lastly we'll talk about chronic inflammation. So chronic inflammation will be pretty straightforward after we get all the way through acute, because everything that happens acutely happens chronically. The only difference is it's long-term. That's the definition of chronic. So it remains elevated, like on that previous slide I showed, where the macrophages come up and they don't necessarily come down. In chronic, they actually, there's a long tail where they continue to tail off. Okay, and continue in an elevated state. And then at the end of the lecture, I'll give you some examples, some application examples of in the research world with biomaterials or biomedical implants, how we modulate inflammation by trying to influence its resolution. So first up, let's talk and characterize the different types of acute inflammation. There's four main ones that I want to talk about. And at the break, someone asked, you talked about four cardinal signs of inflammation, and the book kind of listed a fifth one of loss of function. And there are places, it's a very good textbook, there are places where we would maybe disagree. And so for purposes of the exam, you're going to want to go with what I'm lecturing on. Okay? And the reason I would diplomatically argue in a professional way, loss of function, is it depends. Because there's inflammation that happens at a very low level all the time when we have injury or tissue repair. And the tissue doesn't lose function. Function may be diminished, but it may be not completely gone. So I would actually disagree with that sort of fifth one the book talks about, depending upon the edition that you have, of the fifth being cardinal sign of loss of function. Sometimes yes, sometimes no. Okay? So the four types of acute inflammation that we're going to characterize, we have serous. Serous is a watery, protein-poor fluid, like what you're going to find in a blister. Okay, there's an effusion, there's a fluid in a serous cavity. Fibrinous, the second type. Fibrinous is when there's a little bit more extensive injury than a blister. You have a greater capillary permeability. Now we all know what that means. You have this existing in a lot of the body cavities when you have inflammation within a body cavity. You have fibrinogen that exists. That's why it's called a fibrinous inflammation. You get the formation of a protein coagulum, which is a fibrous protein. Fibrinogen. Superlative, also known as purulent. This is where you get pus. You get an exudate that comes from the neutrophils. The neutrophils that go, the first responders, they go in, they kind of chew up either tissue or in some cases bacteria, and they release an exudate as cellular debris that's actually being broken down. That cellular debris is partly necrotic cells and edemic fluid, and that's where the pus can come from. If it's a microbe that's present, not always, but if there is one that's there, obviously there's going to be pus, but then it's considered pyogenic. Abscesses are an example of a local superlative type of inflammation where there's pus, and oftentimes it's because there's a microbial infection. Okay? The last one are ulcers. And ulcers are usually an erosion of a tissue surface. It's either a tissue or an organ surface, and there's a lot of shedding of necrotic cells that takes place. So if we look at these pictures on the bottom, I'm going to dim the lights a little bit so you can see them a little bit more clearly. In the lower left is a duodenal ulcer. You can kind of appreciate where this gap, this should connect all the way over this epithelium. and this is this ulceration. So you can draw a line to this one as an ulcer. This lower right is a fibrinous pericarditis over the heart. Fibrinous pericarditis, excuse me, that's the upper right. So that's not it. This is the heart tissue here. Fibrinous pericarditis, what are you looking at? All of this whitish tissue, this is reflected back. You can see the instruments here. All of this whitish, dark white, not the clear white, but the dark white is all fibrinous pericarditis on the surface of the heart. The lower right that I was pointing to, inaccurate at first, is the lung. This is a purulent inflammation of the lung. The lung particularly is at risk of microbial infections because it's exposed to the outside environment. Right? So you might see a local abscess there. What are we looking at? Well, all of these purple dots here are all neutrophils that have infiltrated into the tissue. So that's the purulent infection, purulent inflammation of the lungs. You can see vessels up here, blood vessels in the red. And what should be in here is open white space. That should all be open white space in here in the alveoli. Okay, and it's filled with these purple dots. Those are the neutrophils that come in. So if we have acute infection, or inflammation, if we have acute inflammation, we have a couple of possible outcomes that are characterized on this slide. So here's our acute inflammation. These vascular examples should kind of make sense, the drawings, we've explained them. We have our arterial network, our capillary bed, our venule side, and we have some injury that's in the tissue. It could be traumatic injury. It could be a myocardial infarction of the heart, bless you. It could be bacterial infections or toxins that cause the injury to the tissue. And again, this semester, throughout the semester, we'll look at the different types of injuries at the different levels of tissue in the different systems every time we show up in a new week. Well, we've got these vascular changes that we've talked about, and we have cellular changes. One thing that could happen is we could actually get complete resolution. This is what we hope for, going over to the right. That would be the best outcome over to the right, resolution. Look at what happens. You clear the injury. All of the mediators are gone and cleared. The inflammatory cells go away. The macrophages don't stick around. The neutrophils are long gone. This is the best case scenario. This might happen in your tissue when maybe you're 5, 6 years of age, and you fell off your bike and you cut your knee, and you're like, that was so gnarly, and then you look at your knee and you're like, no, I swear it was like this big, and now I can hardly find it. Because young tissue heals very well. We'll talk more about that next week, okay, the different types of healing, wound healing. But this resolution here, like when you're 4 or 5 years old, and you took your training wheels off and then you bit it, it probably healed pretty good, and the best thing that happens is you get a normal restoration of function. Meaning that the tissue goes back to what it's supposed to do. So if it's skin, it grows hair back, right? It creates a barrier again. It'll continue to make vitamin D. Bacteria can't get in. It has its normal elasticity. There's not an aggressive scar that mechanically feels different than the adjacent tissue. It's not harder. It's the same integrity, normal function. Everything comes back. Okay? That's one possible outcome. That's our best outcome. Well, the other possibility, unfortunately, is you could have, let's go this way. We could have some healing that takes place, but when it's over, we've lost the function because there's a tremendous amount of scar tissue. And that's very evident in wounds that we have now as we're older. You have a wound now and there's a really aggressive scar. Last summer I was on the lake and I think we were just way too many hours in a wakeboard, and I had a wound that showed up on the top of my left foot. And I didn't bother with it, and now there's this super really dark scar. It's like, wow, that is so weird. But that's classic fibrosis. And that happens as we get older. Okay? Loss of function. You would see that in a scar like a scalp wound where you pull the hair back a little bit and you can see exactly where the incision happened in some of your friends or family members. Okay, so the loss of function there is the skin didn't completely return function because there's a scar and that's fibrotic tissue, and the hair didn't grow back because normal function would be the hair follicles regenerate. Okay? Now I'm almost conscious about my scar line here. The third outcome could be chronic inflammation, which is where we're headed. Chronic inflammation means that this never resolves. Okay? You never get any healing. You don't actually have a scar and loss of function. It's just really, really wound up in an inflammatory state. And that would be chronic inflammation. So chronically, you have these infections, whether they're viral or whether they're bacterial or persistent injury. Like, for example, with GERD. Remember that first clinical example we talked about the first time we were together? You guys remember that? You were wearing blue, right? Birds were singing. That first time we were together, we talked about GERD, right? Ooh, you just ruined the mood. Okay? And that was chronic injury because that stuff was coming up from the stomach and causing this chronic inflammation. That's what we said back then. That would be an example of persistent injury. Another one is the classification of autoimmune diseases. Autoimmune diseases, whether it's lupus, okay, or multiple sclerosis, or rheumatoid arthritis. These are autoimmune diseases that result in a tissue that's chronically inflamed. Tremendous amount of angiogenesis, right? Remember back here to these drawings? A lot of angiogenesis, you get a lot more cellular infiltrate, and you generate the scar in that tissue that's impacted because this never goes away. You never have a healing that takes place. You definitely never have a resolution. So there's really three main outcomes that you could have as a result of inflammation. You hope that it always is here, but most of the time, clinically, you all are going to be dealing with patients that are in this category or in this category. Okay? Because if all of us did this, you guys wouldn't have any jobs. So it's kind of a good news, bad news. Right? Now, what about this intermediate one that you skipped over? Right? The pus formation. This one's kind of a deviation of basically fibrosis because you can see it eventually goes here. So if you form an abscess, when the abscess resolves, you'll eventually get fibrosis, if it ever resolves. Okay, so that was really not a fourth possibility. It's just sort of a little bit of a deviation from normal fibrosis that takes place. But those are really the outcomes that we can have. Chemically, what regulates these activities of inflammation? We're going to go through a couple of busy mechanistic slides, but we'll do it methodically so we don't lose you. These chemicals show up either at the site of injury or they're circulating in the blood plasma. If it's at the site of injury, then it can come from the injured cells, or it can come from cells that are recruited, which are the leukocytes that show up into the area as a result of diapedesing out and moving into the tissue. Okay, you tracking? So either the injured cells get smacked, histamine gets released, or the leukocytes that are recruited show up, and they either dump packaged in vesicle these cytokines or these chemicals that are already manufactured, preformed. Or they can actually generate them from scratch. That means de novo synthesis. That's what that translates to, is making it from scratch. They can manufacture new chemicals at the site. That's a little longer. Bless you. So if you talk about at the level of the plasma, look at all the things that are found in the plasma. Here's the whole list. And here's plasma proteins that can be manufactured by the liver and can also dump them into the plasma. So we've got histamine and serotonin. These guys are aggressive vasoactive agents. Right? Histamine serotonin are aggressive vasoactivations. They do something to the blood vessel. You can see where they come from. Histamines primarily come from mast cells, but they're found in platelets as well as basophils. Serotonin comes out of platelets that are in the area. And then, so these guys would be these preformed chemicals. The newly synthesized ones you actually manufacture. You manufacture these utilizing leukocytes, mast cells, macrophages, endothelial cells. What do you make? Well, you make a whole family of things, and we're going to talk specifically about a sublist of these. Prostaglandins and leukotrienes, platelet activating factors, reactive oxygen species, we already covered those. Nitric oxide, we already covered those. Those are all manufactured from macrophages in the tissue. This general category of cytokines, like things like the interleukins or the TNF-alphas. And then a classification of neuropeptides. All of these are triggering an inflammatory response. I'm going to walk through a few of these in more detail. This is a broad diagram, and you'll see here in a moment what I really want you to focus on. Liver-derived. The liver can manufacture and put into the bloodstream things like the family of complements. Complements are funny. They're a protein family that's named because they complement the inflammatory reaction. So they're called, as creative as scientists are, complements. Right? It's like if it was up to scientists, we'd all be driving a car. That would be the name of it. Right? What kind of car do you have? A car. Was it a car alpha or beta? Ooh, it's the alpha. Right? That's about as creative as we get. Wow. Wow. Well, the beta version's really cool, though. Well, no, I didn't get that one. Leave it up to the marketing people to have all these clever terminologies, right? So, the complements complement the activity of inflammation. And we'll look at the family of complements like the C3As, the C5As, and the C3B here in a second. Secondarily, all but one of the coagulation factors that clot blood are manufactured by the liver. So, for example, Hagman factor, which is factor 12, activates both the kinin system as well as the coagulation cascade. Why? Remind us why coagulation is important for inflammation. What's that? Exactly. It encourages the cells to marginate to the edges of the inside of the blood vessel, right? That's exactly right. That's an important piece because without margination, therefore without coagulation, controlled coagulation, you'd never be able to recruit those cells to the margin, or to the edge. That's another way of saying it. So if we look at other derived factors, this one's focusing on this family of eicosanoids. These are manufactured from scratch. And I'm going to highlight a couple of these. You don't have to memorize everything on the slide. Eicosanoids are a steroid family. They're manufactured from the cell membrane, and a lipase, a phospholipase, breaks down the phospholipid bilayer and creates a precursor known as arachidonic acid. Then from arachidonic acid, you can manufacture two different main families. Cyclooxygenase to your left, and lipooxygenase to your right. If we follow the cyclooxygenase pathway down, we generate products like prostaglandins, which are down here in this box, PDG2, PDGE2, right? These are two different versions of prostaglandins. There's that creative nomenclature again. Prostacyclines and thromboxanes. What I want you to know is the cyclooxygenase pathway yields prostacyclines, prostaglandins, and thromboxanes. The boxes tell you what they do. So let's just look. This one causes vasodilation and inhibits platelet aggregation. Thromboxanes cause vasoconstriction and promotes. This is the yin and the yang, right? You don't want to turn on something if you can't turn it off. So you want to be able to control it. Vasodilation down here by the prostaglandin family. This increases vascular permeability. So you have vasoactive, generally, these three boxes are all describing vasoactive responses by the arachidonic acid family down this cyclooxygenase pathway. Right? All this relates to inflammation. So for example, if you have inflammation in a patient that's out of control, and you want to prevent massive vasodilation of the blood vessel, we all agree that that's, if you block vasodilation of the blood vessel, you're going to lower inflammation, right? Well, look, if you use a COX-1 and a COX-2 inhibitor, like, for example, aspirin, you block the formation of any of these products from arachidonic acid using cyclooxygenase. That's why aspirin, or COX-1 and COX-2 inhibitors are such potent anti-inflammatories. Okay? If we look over at the right side of the tree, instead of cyclooxygenase, we use lipoxygenase. The main take-home message I want you to take here is that you get this family of leukotrienes, and you get this family of lipoxin. The leukotrienes also have vasoactive activities, and the lipoxins have chemotactic activities. Okay? Again, both of these are related to inflammation. So, if you want to more aggressively block inflammation in a patient, because they're on a COX-1 inhibitor, or they're on an aspirin, you know what? Their chronic inflammation is still out of control. Look at where a lot of our steroids block. They go further up, and they block the formation of arachidonic acid by blocking phospholipase. So you don't get any of these, and you get none of those. So aspirin is less aggressive, and steroids are much more aggressive anti-inflammatories because of this pathway. So it looks like a busy slide, but if you understand where it fits in, and you understand different diseases where you would have inflammation and why you might steroidally want to block, well, you're blocking further up, and you're knocking out more of the family of inflammatory mediators. You also have to be careful, because if you're on a chronic steroid, what do you think is a side effect of wound healing? Do you think it's compromised, or do you think there's no effect? It's compromised. Okay, so long-term chronic steroidal use, systemically in patients, one of the side effects can be diminished wound healing capabilities. So that's where those come from. Cool?
So you were saying when it goes down the cyclooxygenase pathway, on the left, the right version is just its inhibitor. So it's saying you're balancing it out.
Oh, you're talking about the prostacyclin versus the thromboxanes?
Yeah.
Yeah, that's just so that when you stimulate cyclooxygenase, you make the cyclooxygenase pathway, you make two potent vasodilators. So you want to have thromboxanes there to sort of kind of turn it off when it's ready. You don't want it to be, you don't want to lose everything.
So we just need to know the different cyclooxygenases you're saying?
What I want you to appreciate is all of these come from arachidonic acid.
Right.
They're made by this phospholipase converting phospholipids. You have two main pathways. We clinically block this pathway, which is prostacyclins, thromboxanes, and prostaglandins, using COX-1, COX-2 inhibitors, and aspirin. This side uses a different enzyme, manufactures two different products with slightly different but very similar activities. So if we want to knock out all inflammation, essentially, we block the formation of the eicosanoid family.
Okay.
And you just use a steroid, it knocks out phospholipase, you never make any arachidonic
So you
acid.
don't need to know like the specific ones in cyclooxygenase?
No, I won't necessarily ask a question about PGG2 or PGH2, right, or CAR1 alpha, subtype beta, no. But I want you to be able to understand what the family of prostacyclins do, what the family of thromboxanes do, what the family of prostaglandins do. These are all things that have vasoactive responses, and how could you block them? You could block them with aspirin, or a COX-1 or a COX-2 inhibitor. If you block with steroids, yes, but then you also block this side too. So it knocks out everything. So you first see the patient, you may say, let's try something a little bit gentler, and let's see how you do. And then you come back and say, you know, it's still not working. Well, let's ramp it up, and now we might need to use a steroid regime for a few weeks. And then, but I don't want you, you've ever heard the doc say, I don't want you to be on these for very long. So we're going to get you on a steroid so we can get it under control, and I'm going to back off of it. You're like, why the heck would he do that? It's working great. Well, because you need inflammation. You can't knock it out completely. Okay? So that's where the practice of medicine comes in, where you're kind of dialing in, and every patient's a little bit different. Okay. Plasma mediators. These guys are complement family. They're kind of cool. There's three main pathways. The focus of the pathways is not really all that important. We have an alternative, a classic, and a lectin pathway. I wouldn't worry as much about these three pathways. What I'd like you to be able to understand is, what do they do? What do complements do, regardless if they come from one of these three pathways? Well, they have activities, functions, effector mediators, like inflammation. They stimulate inflammation, like C5a and C3a stimulate inflammation. They help the macrophage to find and bind the microbe and ingest it. Okay? C3b, these guys facilitate phagocytosis, the phagocytic activity of actually engulfing. C3a and C5a help with basically the opsonization, identification, and getting it ready for phagocytosis. C3b is the phagocytosis, and then this guy's really kind of cool. This one's called the MAC complex. So this is a membrane attack complex. Here's a blow-up diagram of it, where it's a number of different complement proteins that form a structure in the membrane of the bacteria and allow for it to lyse the bacteria. Okay, so it's a defense mechanism. Family of complement. So they cause an increase of capillary permeability and vasodilation. They help to recruit and activate leukocytes, adhesion and chemotaxis, and they facilitate phagocytosis. So they're complementary proteins that facilitate inflammation. That's what they do. Now, lastly, of these plasma mediators, we talked about the kinin and coagulation pathway, and then I have a summary slide of this little segment to talk about and hit on some of the key points. Kind of try to bring it together like, what is it, Dr. Keller, that I actually have to really know well? That's the next table. Okay. So here, we've got some plasma mediators, and what I want you to see is we got two main pathways. We've got a kinin system, and then we also have the coagulation cascade. So here's our coagulation cascade, or our clotting cascade. Here is our kinin cascade. And both of these are activated by factor 12, or the Hagman factor. Factor 12 goes to factor 12A, and that stimulates both, see, 12A takes pre-calcrein to calcrein. Factor 12A takes factor 10 to, factor 11 to 11A. And as you move down this cascade, you eventually get to factor 1, which is fibrinogen, to factor 1A, which is fibrin, and you get the ability to coagulate. Over on this side of the kinin cascade, you activate plasmin. Plasmin stimulates this complement cascade that we just got done talking about. So the plasma mediators, whether it's the kinin cascade on your left, or it's the coagulation cascade on your right, both are related to inflammation in what way? Well, complement's related to inflammation because it assists or complementary to the pathways of inflammation. And the coagulation cascade is beneficial because it facilitates margination of those cells. So all of these things are happening in concert to stimulate a robust and appropriate inflammatory response. So let's recap. Let's recap this little mechanistic pathway section. We have vasoactive amines, or vasoactive substances. First category. Main ones are histamine and serotonin. Histamine, released by mast cells, basophils, and platelets. That was on that previous slide. I'm just recapping the main take-home points. In other words, focus on this for the exam. It increases vascular permeability. Now we know how that relates to inflammation. It allows these white blood cells to get out, exit into the tissue. Serotonin comes from platelets. Regulates hemostasis and blood clotting. That helps with margination. I keep going back to that again and again, right? Eicosanoids. Remember, the eicosanoid, there's 4 main families. They're listed here. Prostaglandins, prostacyclines, thromboxanes, and leukotrienes. What do? They have main vasoactive effects. That means they influence the blood vessel. They can stimulate bronchospasms. It's one of the side effects. And they also induce chemotaxis, or getting the inflammatory cells to the region of interest. Complement, we talked about the 3 roles that complement plays on vasodilation, activating these leukocytes and facilitating their activity. And then lastly but not least, their role in promoting or encouraging phagocytosis. And then last but not least, the kinin coagulation cascades. Again, this hemostasis facilitates margination. We also said that the kinin specifically, also I would add here, which I should do to this slide, is I would add, what is the kinin system responsible for as well? Complement activity. Okay, so there's a little space there to actually write that down. Questions over that? So the last section is actually really simple. The last, there's some bonus slides at the end that we're not going to cover. They're there because some of you, in a class like this, some of you are just that way. You can't get enough. So I put some more in there for you to look at. But chronic inflammation is very similar to what we've been talking about in these 2 lectures. But the main difference is time. The difference is mostly in time. It lasts a long time. So if you compare and contrast acute on your left with chronic on your right, you can see that these are days after wounding. You can see the first one is inflammation comes up and goes down on acute as it goes away. You can see that then you get this response of cell proliferation repair. Then you get this response of matrix remodeling, but all of these phases drop off. They come up, and then they go away. If we contrast that with chronic inflammation, you can see you get the first wave of neutrophils, and they go away. But after that, everything stays pretty much elevated. Macrophages come up, and they stay forever. New blood vessels, neovascularization, that's what that word means. They come up and stay forever. This is a new term that I'm going to show you here in a second. Foreign body giant cells come up and stick around. Fibroblasts come up and stick around, and you get this fibrotic scarring. So a clue of chronic is if you have some key features that you don't typically see in acute. So let's look at that histologically. So up top is chronic on your upper right. Down low is acute. The acute on the down low is mostly a neutrophilic infiltration. What tissue are we in? This is the lung. Okay, so these are the alveoli borders. The reds are the blood vessels that it's well perfused. And all of this should be white space. You can see there's just a little bit of neutrophilic infiltration, but all of these purple dots are all neutrophils. That's acute. It'll eventually come away, or go away, excuse me. Acute, chronic, up top, you see this asterisk in this bundle of inflammatory cells that are resident. The chronic inflammatory cells are mostly macrophages that are sticking around and elevating and staying in place. And then you actually have, so that's a collection of chronic inflammatory cells, otherwise known as macrophages. You have normal alveoli being replaced by cuboidal-like epithelium, right? That's all the arrowheads right here. And then the two arrows themselves, that's fibrosis. That's the scarring that takes place with these two arrows. That's fibrotic tissue that you don't see anywhere in the acute phase. So hallmarks of chronic are macrophages that stick around in a bundle, like here, this mass right here. Fibrotic scarring, like you see with the arrows. And then destruction, or a loss of function, like you see with the arrowheads. Yes? I answered it, okay. Yes?
So it changes from squamous epithelial to oil.
Yeah.
Is that example of inflammation?
It is an example of some metaplastic responses.
Why does it do that?
It's responding to long-term injury. Yep. Okay, so if we continue on this theme chronically, we're going to see some of the same products, right? We actually see some of the same products like neutrophils with first responders. They activate into tissue macrophages when they leave the bloodstream. Well, the other thing that starts happening is we recruit lymphocytes, B style and T style. We'll talk about those in a couple of weeks when we talk about the adaptive or the specific immune response. So chronic inflammation can actually trigger an immune response long term by the recruitment of B and T lymphocytes. So here's our inflammatory pathway here, right? Here's our macrophage coming here, activating it, and it is presenting to a T lymphocyte. So we're going to roll in inflammation when we talk about our adaptive immunity, we talk about B and T lymphocytes. Chronic inflammation recruits more eosinophils and more mast cells, so histamine levels are chronically elevated. Now, two more histology slides before we end, and then we're done. This one is a classic chronic inflammatory histo. Second one that I've shown you. I'm going to show you a third one right after this. So, this is a granuloma, or an inflammation that results in a granuloma. This is typically found in all sorts of different types of tissues, but this one is actually found in skin. So what we're seeing here is a walling off, number one. You see how this tissue has decided to kind of form this wall and surround this mass. Number two, we see in blue arrowheads what we call foreign body giant cells. These are described in the literature to be the fusion of multiple macrophages into a multinucleated giant cell. So if the macrophage, the idea is the macrophage can't phagocytose and engulf, then what happens is it joins forces with other macrophages nearby, and they right? They fuse together and they form this big mass, and they get another one. So it's not uncommon for these foreign body giant cells to be multinucleated of 12, 15, 20 nuclei, which were probably individual macrophages at one point in time. And they're circumscribing the area to try to eventually digest this away. The epithelioid cells that we see, these epithelioid cells are cells that show up in these lesions that are fibrotic in nature. So that would be what's happening right here in the middle. This is that scarring that's taken place. So you've got foreign body giant cells are walling off, and you've got scar tissue with these epithelioid cells right in the middle. The last application, and then we're done. The last application is what happens around implants, biomedical implants. This is a surgical mesh that's used usually for abdominal reconstructions or pelvic floor reconstructions. Polypropylene, it's very, very common. This is histology in human tissue of polypropylene, okay? And this is the area of the polypropylene. You can see all of these red arrows are pointing to these foreign body giant cells, just like we saw the blue arrows over here. I just used red because blue wouldn't show up as well as it did here. So you can see the relative level of inflammation around polypropylene. it's actually rather inflammatory, and that's chronic. So what we can do is we can coat it with a matrix, right? And you can see the reduction in the number of foreign body giant cells. And so this one, with this coating, with this matrix, would be considered to be more biofriendly. Long term, that mesh doesn't elicit this really aggressive inflammatory response. Okay? So the last section is for you to look at your leisure if you like. It won't be on the exam. Okay? Just that last slide, that's where we end. If you have any other questions, feel free to email me. Have a great rest of your week.